Hey, everybody. Dan Hardle, Mike Hardle, and of course,
Brian Hardle.
Brian Smith joining us today for a special podcast episode. You know, we feel like this one's maybe a little bit of a repeat from a prior podcast episode on the exclusive IESNP.
It's a remix.
It is. It's a remix because, you know, our last episode, which we got tons of positive feedback about, unfortunately caught the ire of some other people in the industry. So we had, you know, we got a call from Brass that we had to take that episode down, unfortunately. So, you know, that's all right. You know, like I said, it's not going to deter us. We're going to get the content and information out there. So now we're just going to have to do it in a different approach, but we're still going to get you the info. So here's the reboot remix of the UnitedHealthcare and Optum IESNP product out there. Hey, everybody, we wanted to make a couple more videos out there and just have a better explanation about our IESNP product through Optum and UnitedHealthcare. So first of all, IE means it's institutional equivalent. So first, very important thing to understand about this product is that it does not mean that somebody has to be living in an institution or facility in order to qualify for the plan. So I think that was, you know, one of the first kind of misnomers out there, I would say, is that, you know, as far as people being like, oh, it's just an institutional plan for these people. No, that's the first thing that I would say about the plan.
Yeah, I'd like to just kind of chime in and just kind of set the table for why we're putting out this little compendium addendum content, because there are a lot of agents out there that are frustrated that they're unable to represent this product, and so they're out there kind of talking bad or diminishing.
Yeah, there's two sides of the coin, right? We're talking and putting it out there about what a wonderful product it is and how great it is and why you should be selling it and why it's great for some of your clients potentially. And then the other side of the coin, we have a whole nother, we'll call it 98% of distribution out there who can't sell this product.
Yes.
Well, to be honest, you know, there is tons of misinformation out there,
right?
Especially down to the UnitedHealthcare level.
Well, so a couple things. It's all the other people who can't sell the product. Look, I'll use the term salty. Some of them are salty, and they're just saying, hey, and so they, I think, are by design spreading misinformation or telling people wrong information that they don't know to try to dissuade agents from caring about it or wanting to sell the product.
Correct. Or they've been told that they're going to be able to sell it very shortly, and that reality that they are not is starting to proliferate across the industry. And so I've seen a lot of agents that are trying to diminish the product by being like, oh, that's just for people that are waiting to die in an assisted living facility, you know, and they're trying to,
or you're not going to be able to get commission off this product.
Right.
Correct.
Yep.
Yeah. So there's a lot of people that are trying to downplay actually how effective it is. And then on the counter side, you have the UHC Optum clinical side that wants to grow this plan that's doing an excellent job, which is why it's a 5-star rated plan in almost every state except for one. And we're having a lot of success, and our clients, it's a really good product to have in our portfolio. And so we wanted to put out a couple clarification videos should there be any further questions.
Perfect. So, yep. So I guess at least for this video, we're going to keep some of these short and sweet. So watch as many of them as you'd like. But I think for this first one, it's an IESNP product. So you understand that it's an institutional equivalent. The other thing I'll have to lean on, Brian, how many states is it available in?
In 2024, it'll be available in 30 states. So Oklahoma is being launched in January.
Fantastic. Good news if you're listening in Oklahoma. So again, 30 states where it's available. Okay. So IESNP, 30 states available. It's actually obviously underwritten, insured through UnitedHealthcare, which is the biggest name out there when it comes to Medicare. And obviously all the clinical risk, everything from the management and clinical side, it's all through Optum, and they do a great job. So again, when you think of healthcare and you think of Medicare and you think of an insurer or somebody out there to put a plan on, who better than UnitedHealthcare and Optum and a 5-star plan with with an actual clinical team?
So let's talk about who could potentially be a good candidate for this product. And it's not just people who are institutionalized or at-home institution, let's say hospice, you know, waiting to pass away, that are the right product for this. It's, in fact, it's very far from there. And we've had, from the source of truth, we've had the content, original content is probably not going to be up when you listen to this. But I want to kind of clarify what kind of people can qualify for this plan, because it is designed to give people an LOC or a level of care that may need some extra help with some things. So let's talk about some of the people that we've been able to get qualified for this plan and how we were able to get qualified.
Can I rock the boat? Should we make one video that's kind of, Omar's going to have to edit here, but should we jump in and kind of do like we did, keep it short to like here's a broad overview of what the plan is, and then just do a separate quick one on who qualifies for it and what does the qualification process look like?
Yeah, I can talk a little bit of its history as well.
Yeah, we can chop it up a little bit. I think it'll be fine in a podcast format and a chopped up video format.
All right.
People roll with it.
We can leave that original content in here.
Yeah. So. Joe Rogan pauses to go to the bathroom. So,
well, I think it's important to start with the history of the product as well. From what I gather, and speaking with sources of truth, like you said, this product has been around for about 3 years, and it's always been a 5-star plan. There have only been roughly 15 sales reps in the entire country that were able to represent this plan, and they were all averaging over 200 of these applications every year. So that's not even a drop in the bucket. Optum wants to grow this plan, and they want to grow it fast, but they want to retain that star rating.
Well, and the limitation on sales was, look, as Brian mentioned, there was 15-ish reps that could market the plan or could represent and enroll people into the plan. And really, it was just their time, right, to do that, doing hundreds of enrollments. They only had so many humans that could do it. So they wanted to open it up to a little bit more distribution because they had everything dialed in. They were expanding into more markets, more states. And so they wanted to open it up to a little bit more distribution, but they can't just completely open up that valve, floodgates, and have everybody sell and market the product. They don't have that scale and that structure in place at the moment. So they do want to slowly grow it in a very efficient manner and not hurt their star rating.
Yeah, and let's talk about the incentive or the reason why a carrier would want to get it, because I've had people ask, well, why do they want to fill it with sickly or more needy people? But the reality is this is the model of care that Medicare and Advantage plans are trying to execute at a high level. Is they want to deliver care and resources to the people that need it. And so on the UnitedHealthcare and the Optum side, they're able to get more resources financially, reimbursement rates to treat those people that maybe do need a little extra TLC. And so there's, obviously a financial component to it, but it's delivering that model of care to those beneficiaries that can really benefit for it. And so that's at a high level, being a 5-star plan, that's how these plans should be executing in a perfect world, right? And so there is an appetite to grow those type of plans.
Yeah, and I think when people have asked me to really and this is a Dan description of the plan, not the official description, but in my mind, it's perfect for somebody kind of in between, like a chronic or a D-SNP, like a C-SNP, D-SNP type member, and a PACE plan. If you're familiar with PACE plans, I think this is kind of a plan that's almost like an in-between, somebody all the way over on a PACE, and then those people who get a little bit of extra services or care on a D-SNP or a C-SNP. I kind of feel like this is something kind of in the middle of those two. Again, that's if somebody asked me to use in my own words or how to describe it, that's how I would describe it.
It's important to know as well that this plan does not have any HRA component at the end of the enrollment, does not have a gym membership benefit.
No grocery
benefit. It's designed for people that are health insecure, not food or income insecure. That's more on the D-SNP side of things.
Yeah, that's a good description. And so anybody that I want to make sure has a little bit of extra TLC, like Dan and I actually wanted to put our father on this plan, and he would for sure have qualified. But we'll talk about why we didn't put him on that. Our parents are never going to watch this podcast, so it's okay. But
he did not want to be classified as one of those people.
Correct. He didn't want to be institutionally equivalent classified, which I think, I've had some sensitivities in putting my father-in-law on that plan too, because I just wanted him. He qualified for it, wanted to get some good level of care on it as well. But he was like, "Oh, I don't know if I'm." Feeling like I'm institutionalized equivalent. I'm like, hey,
have to be.
It's not for that. And it's almost like they don't want that stereotype.
Stigma, yeah.
And that stigma. And really who can qualify for it is people that need help with some of the ADLs, people who are, like you determined, healthcare needs. So I wanted to give a couple example of people that I tested it, because I don't write a lot of business anymore, but I did want to dip my toes with this product. And
I've got agents, in the Northeast that have been writing 80, 90 of these plans. So
yeah,
I've got plenty of stories as well.
So the first I sold was a 90-year-old woman, and she was very, I hope I'm that healthy when I'm 90 years old. She still drove herself. She lived at home by herself and was only on a couple of different medications. And when I did the WellSky call with, set that up and coordinated, her son-in-law, who's also my client, was very concerned about her living at home. She did suffer from some loneliness, isolation, and depression, and then also had some minor issues dressing herself and things like that. And I very clearly and accurately described those conditions, and she was qualified for it.
Yeah, and let's be honest. If you're 20 to 30 pounds overweight, you probably struggle to put your socks on every day or tie your shoes.
20 to 30 pounds, dang.
Yeah.
That's,
imagine being 100 pounds overweight.
Well, you have to actually cross a few lines that you're probably not comfortable with when you're dealing with these people with, certain levels of care, right? Like incontinence, that's a huge problem.
Yeah.
And a lot of agents are kind of iffy about asking about that.
They don't want to,
I know, I get it, but it is really easy to qualify. But every state does have their own qualifications.
But I think if agents are good and they're kind of conveying to people like, hey, just like a doctor, so hey, I'm here to help you.
Correct.
I'm here to find the right, fit for you and get you the right coverage for your situation. And they're asking those questions. So some of that is stepping outside your comfort zone to make sure that you're putting someone on the appropriate plan.
Well, to your point about your father-in-law and how he didn't want to be associated with the word, institutionalized or whatever, that's a big reason why they actually changed the name of the plan. For 2023, it was called the Assisted Living Plan. 2024, it's now called the Care Advantage.
Yeah, I think that's a good
Care Advantage.
Yeah, Care Advantage. That's a great change, because anybody hears assisted living and they think kind of like end of life or unable to.
I'm not that broken down person.
Correct,
Yeah.
or there's a little bit of pride of I'm not that needy health wise yet, but it's like the way I was able to describe it is, hey, I just want to make sure that you have a low max out of pocket. You are going to have some almost guaranteed health issues this year, and I want to make sure that you're protected with a good max out of pocket, and that you're also going to get a high level model of care where I can trust that you're going to have the healthcare resources that you need at a high level to get you taken care of.
Yeah, there's a typical client that I'm seeing that is enrolling in this plan, month after month, and that's a lot of them have Medicare supplements, and that is, and even if you take the premium associated with the plan, if you're paying for a Medicare supplement, odds are you're not going to be on LIS, so you're not going to have any income or any subsidy there for your premium. But even if you fix the premium to the plan and max your plan out of pocket, you're still 9 times out of 10 way less than your premium on a supplement for the year.
I'd say 99 times out of 100, but yeah.
But I think the reason that happens, though, Brian, is because the broker community out there, just in general, is just say, oh, okay, well, it looks like you have a lot of health conditions. You take these expensive medications, and maybe it's covered under Medicare Part B, or for that reason, I'm going to recommend a supplement because you're prone to hospitalization. You have these complex health issues, so therefore you're a supplement person. Right. And so, but obviously with the supplement, all that's really doing is covering their expenses with original Medicare, but it's not giving them that clinical model of care anyway. So they can go off of that to this particular IESNP plan, the Care Advantage, and then they're getting great, coverage as far as out-of-pocket costs and the financial protection, but then they're also getting that clinical model of care.
Right. With that coupled with the UnitedHealthcare PPO national network, it's very important to know that your doctor does not have to be affiliated with Optum. Optum will work in tandem with your doctors and specialists to create that care plan for you.
The other thing that I think is important for brokers specifically to understand is this is all done on the normal UHC chassis too, so to speak. Yep. I'm a car guy, so I talk about like chassis and stuff, like what chassis is it built on? And so I think that it's important for people to understand that there is a little bit of a different process to get this product in your portfolio. You do have to be appointed through us. I think there's one other entity out there, maybe two, that have this particular product, but it's very limited distribution. So there's not a lot of options out there. Again, going back to what brokers can sell this product, it's us and about one or two other brokerages, and that's about it. And so if you're not aligned with one of those entities, you can't get the product. So number one, you can align with us. Number two, we actually have to have a module sent in your Jarvis that's specific to do that training for this product.
Like the D-SNP or chronic model.
Yeah, just like you're used to doing your certifications each year and doing that D-SNP or C-SNP module, there will be a module for you to complete. After you've done that, then it is visible and you can enroll through Lean, and it is on Sunfire now, correct?
Not yet. They're still working on that.
Yet.
I know.
All right, never mind.
So Lean still.
Lean, but again, you're using Lean to write the product. And as far as the whole experience and your commissions and everything else, it's all supported through everything you're used to through Jarvis. It's not like, you're having to check a separate sheet emailed to you once a month or X or Y or Z. This is a supported, integrated product on the platform.
And and you mentioned commissions and that UHC chassis, right? Mm-hmm. That's important. This plan is fully commissionable. Yep. UnitedHealthcare knows how to pay commissions. If you're selling this product currently and you're not getting paid on it, you gotta put your fighting shoes on and call in PhD and make sure they know.
Yeah, so just know that in this same PBP or HICN, for this plan back years ago wasn't commissionable. It is commissionable. So I think that's a really very important thing for you all to know out there too. It's a commissionable product and it's completely and fully supported on the UnitedHealthcare ecosystem or platform.
They're continually looking at this product as well, making it better. They've never really had to do anything to it in the past 3 years because not many people were representing it. So there's one. I've heard a lot of different fight backs about why is it this? Why is it 20% for an X-ray or a radiology service? And why is the drugs this and that? Well, it's not perfect, guys. So they are working on creating more of a traditional copay model for 2025.
Yeah, so let's talk about a basic generic health profile for who, as an agent, you would want to put on this client. Because if you've got somebody that's turning 65 and they're healthy, they're out playing tennis or pickleball every day, they rarely use coverage, they're on low or no meds, this is not the right product for that client, right? Correct. And if you as an agent are trying to shove people on this plan, they're not gonna get approved. You're doing the client and the carrier a disservice, and you're not acting in good faith, right?
You're wasting your time.
Correct. You're wasting your time. Who is somebody who I would say is going to need active care at some point, whether that's they have some sort of basic memory care, they're struggling with some of the ADLs, activities of daily living, balance. They need a shower chair. They use any sort of walker or cane. They have a chronic condition, or they may need a lot of surgeries coming up. Those are the type of people who I'm going to put on this.
But then again, you do have to look at the state where you're selling in.
Yep.
It's completely different state by state. For instance, here in Utah, it's light assist for one ADL.
Yep.
Light assist means a cane. Mm-hmm. Yeah. Or I have to hold to the railing to get up the stairs, or I have a shower bench. That's light assist. In a state like Florida, you have to have hands-on assist for 2 ADLs.
Yep.
So then we have to talk about IADLs as well, those instrumental activities of daily living. That's managing your budget, cleaning your house. So if that's one of the qualifications in the state you're selling in, if they have a messy house, there's one IDL.
Yeah,
one IADL.
People listening right now are like, I've seen a lot of messy houses I've been to. Or
we have how many to do that podcast?
How many of your potential clients are staying really on top of their finances and bill payment? Probably not all that many of them.
I've heard many agents come back to me saying, "Hey, they had their level of care assessment with WellSky, and they either they didn't answer the phone or they were denied, but they totally should get this product. I know that they can pass." And I say simply this: all right, reschedule it. Have your client focus on things that don't focus on things they excel at. Focus on things they struggle with.
Yeah. And I think that on that WellSky, when you schedule that visit, it's pretty quick and easy. And then when you put in notes, I've put in detailed notes from my conversations so that they can focus on that, and the interviewer can focus on those things that I already know are going to qualify them for it. So what I wanted to say is this is not a silver bullet, one size fits all plan that we're trying to convince all agents to shove all their clients on.
Right.
It is that 1/3, 25% of clients that it's going to be a really good fit for, that you just know that it's an excellent plan with an excellent model of care that is going to be delivered from a great company, right?
And I would also add to that and say, like, look, I've been out in the field, I've been in the marketplace, I've had, honestly, thousands of clients myself. And to your point, maybe 25, 30% of the clients are a great fit for it. Yeah, there's going to be more, there's going to be an extra hoop to jump through on the beginning to do a WellSky, basically level of care assessment to see if they qualify for the plan. But if they do qualify for the plan and they're enrolled in it, and the benefits and the out-of-pocket copay structure, it's so low that they have phenomenal financial benefits on the plan, but then they're also getting that level of care that they wouldn't get with another plan. Where are they going to go? Meaning, like, if I do a good job as an agent and know that that person's a great fit, and I go through that extra work to get the person on that plan, they now have like that care manager. They have that clinical team. They're on this plan in my mind forever, in the sense that, like, what other offering is going to come by into the market that's going to be a better, more suitable fit for them, and they're going to give up their clinical team and that management side and better bet. I don't see a product coming in that's going to be better, so I can go, hey, I can put, I don't want to use the term set it and forget it, but I can put my client on that product, and then every year when AEP rolls around, I'm not like, oh, gee, I wonder who's going to come and snatch my book of business and take my clients from me. I can probably go, hey, my 100 clients are on that plan. I'm just going to check in with them, send them my letter, just see that everything's going good on their plan. But it's likely that I'm not going to go out and have to move my 100 people off of that plan.
Correct.
Well, there's never, once they qualify, there's never a redetermination period.
Yeah.
That's the beauty.
Yep. And as we know, as our clients age, they're generally not getting better in health, and they're generally not utilizing less care. It's only going to be more care going forward. So that's only going to strengthen their loyalty towards you as an agent for getting them on that. It's going to strengthen, it's a plan, like you said, Dan, that once the agents put them on, they know they're getting about as good of a care model, and they can trust that, and they have good, stable, predictable, low max out-of-pocket costs, and they're going to feel like you did them a solid by one, knowing about this plan, right, and being able to help them get on it. And the few clients that I helped, after they went through that, like WellSky, they were like relieved. Oh, I did qualify for it. And they know that they went through that extra step to get on it, and they don't want to lose that. So you don't have to worry as much about some call center from, some foreign country telemarketing your client off of this really great.
That happens in this industry?
Yeah, off of this really great plan to go join a plan that's going to get them, $50 more of over the counter.
Well, and you mentioned too that it's not the right fit for the person that's, really active, just turned 65, is playing pickleball and golfing every day. And, but, I will speak from, I've been in the industry for 16 years now. And, sadly, I still have clients that I really love, that I know them by name. I know their hobbies, activities. Sometimes I even know the names of their grandkids. I mean, I have that relationship with some people, but you see them, and then 2 or 3 years later, a stroke happens, or an incident, or a medical, and you see these people who are like, the figure of health, and then as they age or get older or something happens, they're not. And so maybe they're not a good fit for it, but you always have that in your back pocket, so to speak, as an agent, to say, hey, when or if circumstance changes, there's going to come a time in which that product's going to be right for them too.
I started when I wanted to have that experience myself of being the go-to, because I'm the go-to guy here for this plan. Agents come to me for questions and whatnot. So I needed to know how to sell it.
If you're listening, by the way, to Brian, in all 30 states, I would say Brian's one of the most knowledgeable people in the country with this plan.
Oh, thank you. So I started out with my own book of business, right? I wanted to have that experience myself. So I looked at people that I had in the books for, 10 years at least, in their 70s, 75, whatnot, especially people on supplements. If I could recall their current health condition, I would definitely reach out to them first. If I couldn't, I always go to Dan, because Dan has that eidetic memory, and he remembers everybody and everyone's ailments and all that stuff. So he helped out a lot too. But yes, you start with what you know and who you know. But where I see this plan really excelling and really moving the needle is actually in assisted living facilities. Mm-hmm. If you can find that one person, the gatekeeper at an assisted living facility in your state where you're going to be boots on the ground selling, mm-hmm. it doesn't matter if they're currently working with another agent or a group of brokers or whatnot. You come in and you slide underneath and say, well, I get that you're working with those people, but do they have this? And I had one broker in Washington do that with a group home, an assisted living facility type group home. And she was talking to the right person and moved all 19 people.
Yep. That's incredible. One complaint I get about it is that sometimes United doesn't always have the best network of home healthcare providers, or especially here in our home market of Utah. I think that's a little bit more, specific to our local market. But how do you think that at scale the home healthcare network providers compare on this plan?
I don't think it's a problem with the home health. It's more on the lines of the skilled nursing. The skilled nursing facility network is not optimal,
right,
on UnitedHealthcare.
I don't think it's optimal on
most
any
Yeah.
carriers,
And that's
they're very judicious.
Right. If we
generally
get down to the details with them, we'll know why. But that's another podcast entirely.
Yep.
Yeah.
But it really matters if it's going to be someone in a skilled nursing versus someone in a home versus someone at their own home. Right. It depends on where they're at in their health care.
Now, one other thing that we haven't really talked about that is important, you kind of hinted to it at the beginning when we were talking this discussion, is that the way that this product is built from the national team at Optum is the local UHC broker manager, wherever you're at, if you're in Oklahoma or Texas or Florida, wherever you're listening to us, your local broker manager and director for UnitedHealthcare, they're not familiar with this product. They don't have access to it. They don't support it. They don't know about the copay structure. They don't know about the level of care.
Those numbers don't roll up under them.
It's not in their sales portfolio.
Even your local Optum reps.
Correct. So if you're like, oh, you know what, I heard about this thing on the Agent Boost podcast, I'm going to go talk to my local UnitedHealthcare and I want to sell. It's not going to happen. I'm going to try to save you the exercise and the hoops to jump through. Your local broker manager and director don't know about it. They're not familiarized with it. They don't support it. Same with your local Optum team. They don't do it. There is a special kind of carved out support team that we have from Optum who we have as points of contact that, obviously we can go to for support or issues or anything else. But that team also has flown out and they will do trainings in person. They'll do remote trainings for us. And then, of course, it's kind of a train-the-trainer model where they have very much empowered and trained us and our staff and our team. And we're out there trying to make sure that you're all up to speed, understand the product, the suitability, how it works. But that's kind of the chain of command or how it's working with this product. So please, please, please understand that you can't hear this podcast and then go run to local market and get, access to it or support for the product.
Correct.
Yeah, let's talk about a couple of other reasons why, as an agent, you should want to sell this, why it's kind of that. And I'll start off. I think that as an agent, you're always wanting to have any sort of competitive advantage, right?
Sure.
And with UnitedHealthcare especially, let's just be real, they have the most enrollees all across the country. In many markets, they're very dominant. And our local market has been such historically. And a lot of times as an agent, you come across people and they may be on a UnitedHealthcare plan and you go, I'm not really going to better their situation sometimes by putting them on this. You might sell a lot of United or operate in a very United-dominated market and still be able to improve a lot of those situations and move them and know that you're doing what's best for the client and still be able to get that client on a book where they otherwise would not have moved. So those are two things for me. One, that getting that competitive advantage and being able to operate in an already potentially saturated or highly penetrated market and have a lot of success with this plan.
Yeah. Well, I think having that Optum clinical team on your side, they'll actually help fight for you. So when you're struggling to get a home health care provider to come to the home, leave it up to the clinical team. Mm-hmm. They will schedule that for you. Even it doesn't have to be Optum. They will come out to the home, provide a care model for you, and then if you need any assistance with home health care, they will set that up for you.
So the other thing I would talk about is even phone sales and selling it over the phone and enrolling people in the plan. So one of the things that I've always tried to train agents, and I kind of create an entire sheet of all these questions to ask people. Far too often in the business, I hear people chasing, down to zero or to, trying to save people money. And half the time or more, they don't want to save money. The person they're on the other end of the phone with, they're like, well, hey, I've got this person that's potentially interested, so I'm going to just spew all these benefits and copays and talk to them about saving money. And that is not even the objective or the interest of the person on the other phone, on the end of the phone. They want access to network. They want a better experience. They want to be able, like whatever that is. Sometimes the sales rep doesn't even ask the right question and they don't listen. So I've spent so much time creating all these questions and value points and like, what made you join the plan that you have? Why? What do you like about your plan? Why did the agent recommend this plan to you in the first place? All these different find out questions. And so when I sit there and think about sales and I always think about it more of helping your client, right? And if you're doing a good job and, you're chasing things, trying to sell somebody a plan to save them $200 a year in copays, I think about selling over the phone and talking to prospects and saying like, hey, are you happy with your current plan? And what about the coverage? And are you happy with like the kind of care that you're getting? If I'm on the phone, I can be very differentiated in having this product in my portfolio and be able to ask them more questions about how happy they are with their plan and their coverage and that clinical side. And I think for me, that's a lot more valuable and to be able to, quote, sell or enroll somebody in that.
So you're alluding to an actual needs analysis?
Yeah, I know, right? So
you don't sell just on who can give you the most dental credits or who
OTC benefit,
or who's OTC.
You get $10 more in grocery and a utility card.
Change your entire health insurance plan just based on that. Yeah, I mean that's
so again
such a disservice.
If you're here, think about that. Like how different is that interaction if you have this product and you can be talking to someone 10 states away and say, hey, do you struggle with any of these things? I don't know if you qualify for this plan, but let me ask you some questions. And if you do qualify for this plan, like this is kind of what you would be getting from a care perspective, and you're getting more than just copays with this plan. You're getting this type of care that goes along or is associated with it. And for me, in that sales interaction and providing value, and then also being able to come home at the end of the day and feel like, did I do something to make a difference and positive and good in the world today? I can feel great about it. If I enrolled 3 people in that plan and, and I check up with them in a month and go, hey, how's your new plan going? I am very optimistic that they would be giving positive feedback about how much they like the plan.
This plan would be a nightmare for any large conglomerate call centers to adopt.
Right,
a total nightmare. You have to be able to know your client and keep your client. Right, you have to know retention. So anybody out there that was struggling with this plan during AEP because you weren't able to just roll out 100 deals of this, that's okay. This is the long play with this plan.
Well, not only that, but to that point, I've noticed it in any sales encounter, there's always that potential takeaway, right? People, even when I'm looking at trying to convert somebody that's on a DSNP on a dual plan, and you're trying to get them to enroll in a DSNP, it's like, hey, you may qualify for this, right? People love to qualify for things. And almost with this plan of, there is a health component. It's almost like a negative qualification, where like, I don't know if you're unhealthy enough or needy enough for this plan, but I want to get you really good care and let me see if I can qualify you for it. They really gravitate to that and they do want to qualify because they want that help. They want that security knowing that, and it almost operates like that takeaway where the few clients that I helped with it, they were very excited to find out that they actually did qualify for that model of care. And then they had that extra level of assurity going, wow, yeah, a nurse called me and went through a questionnaire and I know that I'm going to be able to get that care that I need if and when I need extra resources.
Well, and I can't personally speak to this. I'll own it. I haven't written one of these plans. I've been out of the saddle for a few years myself, but Brian, Mike, you guys have both written the plan. How often do people get on it and then they call you back and they're happy or they refer you to, oh, can you talk to this person or this friend or whoever that I know? Yeah. Is that
happens every time? Every time.
So I think it's also a very highly referable plan, just kind of like when you're taking your AHIP and you're talking to Vivian, who, don't you love the AHIP questions? But talking
Agent
about...
View.
Yeah, like a DSNP plan or, those questions on AHIP. But it is true that when you put somebody on this kind of special, unique type plan and people do qualify, they're a lot more prone to refer others to the plan too.
Watch, you're going to see a couple IESNP questions on AHIP next year.
No way.
Just to freak
Well,
people
well,
out.
it's more relevant than
people
a lot of the PFFS and a lot of the other,
Dude,
you know,
I can't remember. I think we still had cost 831
Cost plans and-
cost plans
yeah.
on there this year.
Well, if you plan on selling this product by benefits alone, please don't.
Yeah.
You're going to do a huge disservice, and you're going to drive the star rating down.
And this is one where I rarely do this on any of our content that we put out there and plug. And, you know, we really just have a very holistic, just industry podcast out there. And I actually think most of our listeners are not agents that are aligned with our agency or do business with us. It's just people in the industry in general. But I will say with this type of a product, you do need to kind of know what you're doing. We do want to train you. You do need a little bit of extra guidance and hand-holding, you know, to understand the product. And I actually think that's one of the things that we do just phenomenal, you know, here at Agent Boost Marketing is we train and we spend that time and try to make you into not just a person that can sell something potentially, but we try to make you really understand it and be very well trained. So I think we're very equipped to do that. So if you're thinking about this product, yeah, please hit us up and we'd be happy to onboard you and actually give you very specific training to this product.
Yeah. Any other final thoughts about how an agent can position it, or what other potential benefits it is to the agent to be able to represent this plan?
Well, if it's easy if you're a field broker, right? If boots on the street and you're actually out there in the community and you see people, you can qualify someone just by looking at them. It's unfortunate. I hate to say we're typecasting people, but you definitely can in this demographic. Mm-hmm. So that's a big thing to do. But then again, think about your own current book and how you can support and retain them.
Yeah, one of the reasons, if it seems like we're hitting this hard, we are, and there's a reason why. And for me, you know, in my role as president of sales, where I'm always trying to help our agents have a reason or be able to generate leads, and I look and go, what's happening in our industry right now? If I'm an agent out there, I want value. I want a reason why people should work with me, clients and facilities. And if I can go to all of these different nursing homes, skilled nursing facilities, group homes, food pantries, all of these different community centers, and I can say, hey, I know you maybe have been hit up by other people, but I have access to this plan, and let me tell you why I think this is going to help all of your clients. And I'm that level 10 expert resource there that has access to this. I know how to get people on. This is a marquee product and a marquee plan, and that's going to allow you to have the value and the authority as an agent to go around and be able to have that value proposition to carry out into the market. If you're just not, you know, nothing that differentiates you, you're just out there scrounging with everybody else.
And what Mike is saying is become a very savvy agent who really understands this product and go leverage that for all those mediums he was just talking about. Talk to the director of the food bank. Talk to the person that's the director of the senior center. Yeah. Talk to the people at Health and Human Service there locally. All these community, these facility managers, all those people out there that are these very smart, authoritative sources that are actually out there trying to help, you know, those same people that you're trying to help. You know, instead of going and doing a one-to-one sale, go sell somebody and then go make 19, 20, 50, 100 sales transactions by selling that one.
Like Brian mentioned, that broker in Washington that sold 19 in one facility. That's a 2 months worth of good production for a lot of agents, right. You know? Yep. And if I was a new broker starting out, if Mike was resetting in the industry, I would go print a lot of the approved assets that UnitedHealthcare has approved for these.
Which they're working and coming out with more.
They have.
Yes. And I would go around and I would hit the Google machine and I would think of as many different types of these facilities, opportunities, brokerage, you know, that I could go around and say, hey, here's a product that I exclusively represent and why it's good for your clients. And I would go build that network of resources in my local counties and communities first. And I would establish myself as my local expert and authority with that and take advantage of it as much as possible.
Have you ever been to a 60 or a 55 and older community?
Have I?
Do you have how many people have wheelchairs and canes and anything that are just walking up and down the aisles there?
Oh, I mean, your sky's the limit, right? Yeah. I mean, disability people,
seniors that are high
people that are on you know, that are getting it through disability. There's so many different people who are going to be able to qualify.
Imagine going to an assisted living facility, not like an actual like dementia care facility, but just like an assisted living. Yeah. I mean, you got 300 residents there, And, if you can go, talk to the director, go give a presentation, again, sky's the limit. Maybe you walk out 3 months later with 250 enrollments.
Well, that brings up a good point. Optum really is trying to ring the bell about this plan and how it increases the life expectancy of their residents.
It does, and it increases for the businesses, the beds, heads in beds, so to speak. It extends out the average length of time. So, when you really understand it, you can do a win-win-win where it's like, hey, this product is a win for me as a broker, and here's why. It's a win for the consumer, and this is their level of care and the outcome, and it's a win for you as the facility because, how often do I hear providers complaining about how awful Optum is? Never. They're always talking about how they like those reimbursement payments or those risk-based arrangements and how they do a great job. And so it's like, on average, those people stay in beds longer. And that's more billable and revenue for the facilities. And so I'm just telling you, the facilities like it, the patient or the client likes it, we like it as a broker, and it really is a win-win-win.
So when the client is hitting their max out of pocket in month 3 of the year, they don't have to worry about those healthcare costs anymore, because we all know how expensive those assisted living facilities are.
Yeah, and Brian, what are the ranging benefits? Vary a little bit state to state, but what are the ranging MOOPs?
From $500 to $1,600.
So just if you heard that, some states the max out of pocket is a whole whopping $500. Other states it's $1,600 at the top end.
Yeah, I just want to clarify so people don't misunderstood. This plan's not paying for their assisted living facility. I just wanted to just in case any of you misheard Brian saying that. No, this plan is not paying for an assist. It's maxing their healthcare costs, not the facility costs.
So it frees up that money that family would have had to spend on healthcare.
Yeah, and just kind of to wrap up, guys, we all got in this industry, especially on the Medicare Advantage side, because it's a product that, when it works well, it is a win-win-win, like Dan said, and we love it. And this is a model of if and when it can work well at this product at its peak performance and its peak optimization for the clients. And what's better than extending the life of people, getting people that need the care, the actual model that they need, and hey, you can go make a buck off of it. What's better than that?
And we'll have consistent trainings throughout the year, so you can go on our site, you can get in contact with us, you can attend a Zoom training where we can bring up benefits, we can spend more time to educate you on how the product actually works and teach you how to go leverage it. So just know that that's going to be a recurring theme next year and a cadence that we're going to be doing to make sure you're all trained. So
absolutely.
Thank y'all.